Good evening, everyone. I am Dr. Anirban Datta. I am a cornea specialist working at Chirag Eye Care in Lukarganj, Prayagraj, Uttar Pradesh, India. So, the purpose of this video is to discuss my experience while giving the FRCS Glasgow Ophthalmology exam in February of 2024. So, as a brief introduction, I appeared for the FRCS exam on the 3rd and 5th of February at Bangalore, and I was fortunate enough to clear it on my first attempt. It's an easy exam to pass. Unfortunately, it's equally easy to fail. It's a test of your ability to handle stress, and that is all that it boils down to. If you can handle stress, you will clear the exam. So the study resources which I referred to were Kansky, which is the most important reference. Read every page, every line, and every word of this textbook. Other than this, the Muthuswamy University group was excellent. And the Professor Muthuswamy has started this great initiative for people like us who are appearing for the FRCS exam. You can Google it and drop a mail to Professor Muthuswamy requesting him to add you to the WhatsApp and Telegram groups. So they have mock exams and they have some very dedicated volunteers who will guide you with regards to preparing for this exam, and it is completely free of cost. Dr. Hamdi's ICOS lecture series was also useful. However, you have to buy this, and it does have a, a significant amount of money which needs to be paid in Indian rupees. Dr. Chua's book was based on clinical exam techniques, which is the gold standard for the past couple of decades, I feel. And all candidates should go through it line by line, word by word. Dr. Chua's website is legendary. He has excellent videos regarding the various presentations of ptosis, third nerve palsy, sixth nerve palsies, cover and cover tests, and so on. Past candidate experience is extremely important. I went through them for the last 4 years. Other than this, most of my colleagues would recommend going through the past experiences of at least their past 9 or 10 years. Due to a paucity of time, I restricted myself to the last 4 years and I went through them repeatedly because a lot of scenarios will get repeated in the exams. So the past experiences are very important. The Oxford Handbook of Clinical Medicine is very much relevant to our preparation, especially the emergency section, which is last 40 to 50 pages. So you should go through the flowcharts in detail because that will help you clear the general medicine station of the exam. So on day one of the exam, we have the viva or the oral segment. So the viva structure is basically there will be three tables and each table will have two examiners. So you will be getting 20 minutes per table or 10 minutes per examiner. At the end of 10 minutes, a bell will ring. The second examiner will take over. Once the second examiner has completed, the bell will ring again and that table will be over. You will come out of the room and then they will call you back in for the second table and similarly for the third. So it happens very quickly. The exam was over within an hour and you don't get any time to think. The arrangements were good at the hotel and and refreshments were available, even though I feel it is quite hard to have an appetite before appearing in the Viva. So the first table was lids, oculoplasty, and anterior segment. My first examiner was Dr. Tosef. So the examiners will introduce themselves to you by their name. So the first scenario I had was a photograph of a gentleman with drooping of the left upper lid. The questions I was asked were, firstly, the likely etiology. Next, the type of levator function here. Next, the plan for him. What would I do for this patient? And finally, the complications of ptosis surgery. The examiner wanted to know what can make the patient unhappy here post surgery. And he was very particular about wanting to know about the contour issues in this eye. So he's pointed at the lid margin and asked me whether there can be a contour issue. I picked this up and I replied that we can have lid notching. So they have certain keywords which they are looking for. The second scenario was a 50-year-old man with unilateral watering of the left eye. So we began with what will be my approach to this patient. So I started with the need to differentiate between paradoxical watering and drainage issue. Next, I mentioned the need for inspection to rule out facial asymmetry. The discussion veered over to long-standing facial nerve palsy, cicatricial ectropion, and so on. He further asked me about the types of tests. So I began with the fluorescent dye drainage test and syringing. He wanted to know about anything less invasive, and I answered about Broplast or regurgitation on pressure over the lacrimal sac region. At this point, the bell rang, and examiner number two, Dr. Patton, took over. The first scenario was that of a chemical injury. So I started with the management, copious irrigation, checking pH, etc. So then the questions moved on to the treatment regimen I will follow for him and the long-term sequelae of chemical injury. So I specifically mentioned the need to monitor the patient for possibility of glaucoma in the long run. So this was also a keyword they were looking for. So you will be knowing most of the answers because I'm sure when you're appearing for this exam, you're prepared well. However, the examiners don't want to know everything. They just want to know the certain keywords. Hence, try to keep your answers short and try to focus on the keywords. It will save you time. Next scenario was a patient with anterior uveitis who had developed a cataract. Again, the discussion was about my approach to the patient. I began with the need for counseling him thoroughly and about the risks of cystoid macular edema. So, when will I operate the patient? What will be my precautions while operating on the patient? He wanted to know what I prefer when dealing with a small pupil in these eyes. The next discussion was about post-op complications, where I mentioned cystoid macular edema. The management was discussed, and I went through all the details quite thoroughly because I had prepared for this question. However, I mentioned that topical NSAIDs were to be given at 1 month, which was wrong. I should have mentioned that this could be at day one. The examiner very kindly gave me a second chance, and I corrected myself. The third scenario was a lady planned for cataract surgery under local anesthesia. What history will you take? So this was a written scenario. I began with systemic history, need for blood sugars, blood pressure, and at this point the bell rang. He smiled and sat back, and this was the end of my first table. The second table was for glaucoma and posterior segment. So I had two examiners, both appeared to be Indian. The first scenario was post-op day one, post-trabeculectomy, shallow anterior chamber with low intraocular pressure. So we began with what will be the differentials, how will I differentiate between bleb leak and overfiltration, and how will I manage each. So we discussed the management of overfiltration, and he wanted to know about more conservative measures. However, I could not recall them correctly. I did mention viscoelastic injection in the anterior chamber. However, obviously, this is not a conservative measure. Uh, my recommendation to my colleagues would be that when in a scenario like this, it's always better to say that you cannot recall at the moment. He then moved on to Blebleak management, and we discussed about what is Siedel's test, what Siedel's positive means. Again, the discussion was about conservative management, and I mentioned whatever measures I could recall at the moment. And lastly, I will go for Bleb suturing. So the next scenario which I got was a fundus photograph showing a lattice degeneration with crisscrossing white lines, as you can see in the photograph here. This was pretty similar to the photo I got in the exam. So you have to begin by describing the lesion. And at this point, he stopped me and asked me, what will I do for the patient? I mentioned that he may require a barrage laser. The discussion went on to indications of barrage laser, and I rattled off the list which I had memorized. And I mentioned pseudophakia and aphakia as one of the indications as well. At this point, he caught hold of the fact that I had mentioned pseudophakia and aphakia and wanted to know when will I barrage a lattice in pseudophakia or aphakia. So I wasn't very sure about my answer at this point, and I forgot to mention that vitreoretinal fracture in pseudophakia should be the deciding factor when answering this question. I would recommend all of you to read the American Academy of Ophthalmology guidelines regarding the indications for barrage laser in lattice. They really cleared up my concepts. I read this after my exam. So kindly read this before the exam. It will definitely help you. So at this point, the first examiner's time was up and the second examiner took over. So the first question was, what are the causes of angle closure glaucoma? This was pretty straightforward. I divided the answer into pupillary block and without pupillary block and listed the causes as they came to my mind. There were no cross questions for this scenario. The second scenario which I was given was, how will I ensure that pupillary block is prevented in an eye with an anterior chamber intraocular lens? So I replied that I need to perform a patent surgical peripheral iodotomy. The next question was, how will you check patency in the operating room? I blanked out at this point. I should have mentioned that I need to check for transillumination in retro, which is a pretty simple answer, but unfortunately it did not occur to me during the exam. The third question was about a lady with sudden onset floaters and flashes in one eye and how I will manage. So I began with mentioning posterior vitreous attachment. The discussion went into the management. I mentioned the need for in-depth ophthalmoscopy, peripheral retina evaluation. And she further asked me about my management for incomplete PVD. I mentioned surgical intervention first, which is wrong. We should obviously start with the basics first. So I restarted my answer, went into slit lamp evaluation. I mentioned Weiss ring, Schaffer's sign, and after Schaffer's sign, the next question was the investigation I would do, which would be a B scan. So the last question she asked me regarding this scenario was, if there is no break, what will you do? So I mentioned that I will observe, I will explain the warning signs to the patient, and I will review her at 1 month. The last scenario which she gave me was was a black and white photograph, as you can see here, which was of an ICGA. So I took a long hard look to be sure it's not an FFA, but the disc was jet black. So I stuck to my guns and I said that this was an ICGA. She did try to confuse me and ask me if I'm sure, but I stuck to my answer. She wanted to know why I had said that this patient is having an ICGA. At this, I mentioned that the disc appears to be black. She was not happy with this answer. She said there is some other reason, but I was not aware of another reason for labeling this as an ICGA. Ultimately, she said that, okay, you did get this right, it is an ICGA, but your reason justifying it is incorrect. She wanted to know what I'm seeing in this photograph. I pointed to the brightest area in the macula and said that this could be an IPCV. I did not know whether it was an IPCV or not. I just assumed that because it is an ICGA, there should be an IPCV. Later on, I realized that there were some fine dots above the disc, which were actually the area which I should have pointed out. So she was not happy with my answer in this scenario. And then she moved on to the next question, which was the difference between ICGA and FFA. I started with the molecular properties, and as I was progressing, the bell rang. And she said, "Oh, that's all." So I came out of the room. So my second table was over by now. And this was actually my shakiest station in the orals. I had to stop and restart multiple times and I had to pull myself together. I took a deep breath and I told myself that if this station is tough for me, it is tough for everybody. So this was my mantra throughout the entire exam. The exam is tough for everyone. Everybody is in the same boat. So I was called back into the hall for the third table, which was neuro-ophthalmology, ocular motility, and general medicine. So my first examiner was a Middle Eastern gentleman who was very nice. And the first scenario which I was given was to differentiate between paralytic and non-paralytic squint. So I rattled off the differences as quickly as I could. The next question which he moved on to was management of sixth nerve palsy. I had prepared well for this scenario and I was very thorough in my answer. So I went through all the points mentioned in Khan's and I did specifically mention the need to rule out an acoustic neuroma. So the examiner was happy when he heard this. He smiled. Next, I mentioned vascular risk factors, need to check the fundus for retinal hemorrhages, diabetic retinopathy changes, and so on. And the discussion went on to indications for neuroimaging and finally, surgical options for this condition. I explained the principle of muscle transposition surgery. The third scenario was a fundus autofluorescence photograph as shown here, which showed optic disc drusen, as can be seen. So the scenario was that of a 26-year-old girl with no headache and disc swelling. I explained my findings in detail. He wanted to know if there are other tests I would do. I mentioned OCT and B scan. Other than this, he wanted a simpler test which I would do in a busy OPD. I was stumped. I did not know what to answer. Later on, one of my colleagues did mention that it's possible that he wanted to hear about the use of a green filter to find the optic distribution. However, I'm not sure if that is what he was looking for. He next moved on to the complications of optic distribution, which I wasn't very good at. I admitted that I was more aware about the association. So he asked me, okay, doctor, tell me about the association. I mentioned retinitis pigmentosa and Alagili syndrome. Final question which I was asked by this examiner was, which squint has diplopia, paralytic or non-paralytic? So I replied paralytic and he sat back with a satisfied expression. So our second examiner was the physician, Dr. McGrain. He was a Scottish gentleman and it was a bit difficult to catch his accent initially, but it is manageable. You can understand it. The first scenario was that of a 70-year-old female with osteoarthritis who presented with upper gastrointestinal bleed. So he wanted to know how I will manage the patient. I started with airway, breathing, circulation, then moved on to IV lines, blood for cross-matching, crystalloid solutions for infusion. He seemed satisfied with my approach and asked me to show how I will draw blood. And he asked me the reason for bleed in this patient. The next scenario was that of a young female with one-sided headache and ipsilateral dilated pupil. He wanted to know the differentials. I answered with third nerve palsy as my first differential, possibly because of aneurysm or hemorrhage. Next, I mentioned migraine. He was happy to hear migraine. So after this, he asked me about management, and I said that I will perform a Glasgow Coma scaling score as well as neurological evaluation. He specifically wanted to know what I would examine the eyes for. So I rattled off about pupils, Dolce maneuver, and fields by confrontation. Next question was what I will do next. What will I do next for the patient? I mentioned neuroimaging, which is CT with CT angiography. At this point, he asked me about what are my what is my knowledge and what do I know about hypertension and the eye. So these were his exact words. What do you know about hypertension and the eye? I spoke about hypertensive retinopathy and I mentioned that venous occlusions are more likely here. The next question was, how will a venous occlusion patient present? I mentioned the symptoms and then he asked me about the risk factors. So this was again a strong area for me. I mentioned everything written in Kansky 8th edition. He nodded, the bell rang, and we were done. So this concluded my oral exam. And my immediate assessment was that I should clear the oral segment. However, the second table was a bit shaky. After this, once the exam was over, I went back to my hotel room. I had a late lunch and slept off. And you will get 1 day gap between the exams. So if you are having viva on day one, your second day will be a holiday. You can take rest, and the third day will be a clinical exam. So please utilize the 1 day gap that you get to practice your clinical exam technique. Ideally, you should be practicing all the techniques in your clinics from the day you get the notification that you will be appearing for this exam. So start practicing all the techniques on your patient, like ptosis evaluation, pupil evaluation, extraocular movements. Go by the Chua book and practice it on your day-to-day patients. Only that will help you gain confidence. And when you get this 1 day gap, try to practice the techniques on each other, whoever your study partners are. So I practiced the technique thoroughly for the next 1 day. And the big day was finally there on the 5th of Feb 2024, and I could hardly sleep. I reached my center early. My center was Narayan Nitralaya. So the exam structure is that there will be 4 rooms and there will be 2 examiners per room and 2 cases, minimum of 2 cases per room. So you are expected to examine at least 2 cases, and in some case, sometimes you might be asked to examine 3 cases as well. So roughly you will be getting 6 minutes per case. This is the equipment I carried. There is no need to carry anything actually. You will get everything at the center, and Narayan Netralaya was an excellent center. However, there are some candidates like me who are more comfortable using their own instruments. So, if you want, you can carry these things. This is very important. I made sure to greet my patients. The examiners will mark you not just on the basis of a clinical knowledge, but also on your non-verbal cues, how you are dressed, how you present yourself to the patient, how you thank your helping staff, and how you greet the examiners. So try to keep a smiling face and always show a confident attitude while appearing for the exam. And lastly, please clean your hands thoroughly with sterilium in between each patient. This is extremely important. You will be negatively marked if you don't clean your hands. The first room was neuro-ophthalmology and ocular motility. My first case was that of a young girl with glasses, and I was asked to perform ocular motility, but naturally I had to begin with Hirschberg's and cover uncover first. I followed the protocol given by Dr. Chua to the letter, and on observing closely, I noted that she had latent nystagmus. He wanted to know what I would do for testing this kind of nystagmus. So I mentioned that I would like to check for dampening on convergence. His next question was, is there anything you would like to do before that? I couldn't answer this. My time was up. The British examiner took over at this point, and she asked me to examine a middle-aged gentleman for all the cranial nerves related to the eye. I started with the routine nerves, which we all do, and she stopped me when I mentioned pupils. She told me to examine the pupils, and at this point, I followed the instructions to the letter, and I was very thorough with the exam because I have practiced pupil exam multiple times ever since I got the notification. In fact, I feel that pupil examination, while considered easy, can also be very difficult to perform in a high pressure situation. So you need to practice this particular technique again and again and again because there are many steps you need to keep in mind. However, I diagnosed that the patient had a definite RAPT in the right eye. I stated my findings. She seemed satisfied and asked me to move on to the other nerves. I started to do the motility evaluation, and I asked the patient if he can see the target, and subsequently started performing versions. At this point, the bell rang, and she said that this will be all, I guess. I came out of the room and immediately was whisked into the second room, which was for oculoplasty and lids. The first case I got was a young male with right-sided ptosis. I was told to examine him. I began with inspection. I did a whole body general survey of the patient, and I mentioned that the hands appeared normal. At this point, they asked me why did I mention the hands. So I replied that I was looking for muscle wasting, which could be there in the hypothenar eminence of the hands in Pancoast tumor patients, and this can cause horners. Both of the examiners were very pleased to hear this, and they smiled. So this is somewhat the clinical picture I encountered. And the next instruction which I received was to perform the ptosis evaluation. I went through all the steps thoroughly, and I spoke my findings while examining the patient. So my habit is to mention the findings as I go along examining the patient. I find this easier to do. He asked me about all the ptosis evaluation uh, steps in detail. I answered them to the best of my ability. He then asked me whether I can do anything particular for this patient, and the discussion went into frontalis sling. So we discussed about the sling material, and at this point he asked me, where will I harvest tensor fascia lata from? I mentioned that it will be the lateral aspect of the thigh. However, I was not sure about the exact landmarks. The second examiner at this point called me to the next patient and gave me a torch and told me very seriously, Doctor, please examine her pupils. I started with inspection and immediately noticed that she had a right eye customized ocular prosthesis. So the moment I diagnosed this, the discussion went on to indications for eye removal and what tumor will you see in this patient and the types of surgery that need to be done for removing the eye. He wanted to know how I will counsel the patient before evisceration, and I made an error here. I said that I will need a second doctor to evaluate her and sign off on the decision to eviscerate her. So this is the system in India. However, this is not how it will work in the NHS. So please keep these things in mind while answering the question, because this is a British exam. You are expected to answer as per the British guidelines. So anyway, I corrected myself and I said that I will take my own decision regarding this. The bell rang and the examiner smiled. I had a good feeling overall about the station. The third room was anterior segment station, and I had a Middle Eastern examiner and a British examiner. The first case was pseudo exfoliation in the right eye. So this was right down my alley. I was quite strong in this area and I described my findings in details. I was pretty confident while answering the questions, so which were again pretty straightforward questions. He wanted to know what else would I look for in the eye, and what investigations I would do. He wanted to know whether there is any particular investigation in addition to everything I mentioned, and I finally said that I would like to do a specular. He seemed satisfied with this answer. The second case which I encountered was that of a young boy with keratoconus in the right eye. The Middle Eastern gentleman told me to just examine the eye and tell me the positive findings. I did so. He discussed he discussed with me about the other clinical signs in keratoconus, and the discussion went on to management. So I answered these questions quite well. He asked me to examine the other eye. It had a full thickness graft, and the bell rang as I described my findings. At this point, he said, "That will be all, doctor. Thank you." I was quite happy with my performance in this station and felt that I will definitely clear this. So finally, I came to room number 4. So this was the last room before the conclusion of the exam, and I could finally see the finish line in sight. So this was the posterior segment room, and I had two examiners, both of whom appeared Indian. The first case which I got was that of a middle-aged lady, and I was asked to perform a 90 diopter examination of the right eye. I noted pigmentary changes at the macula with a wrinkled cellophane-like appearance, and once I started tracing the arcades, I noted an temporal branch retinal vein occlusion. I mentioned that this was an STBR view because I was in a rush. However, I corrected myself obviously and said this is an ITBR view. The next question was regarding my plan for her, and a discussion went into the investigations, the systemic parameters, and he asked me ultimately, "Doctor, everything else is fine, but won't you check her vision?" I replied, "Yes, sir, I will." "The vision is 636, doctor. What will you suspect?" My answer was macular edema. He showed me the OCT. It had a normal foveal contour. The next question was, "So, doctor, what could be the reason now?" I replied, "Macular ischemia." He nodded. "What will you do for her?" was the next question again. I answered with fundus fluorescent angiography and finally OCTA or OCT angiography. So this was the conclusion of my first case. Now the second case which I was given was another middle-aged female, and I was asked to perform a 20 diopter exam of the left eye only. So she had multiple white-colored fibroproliferative changes in the periphery. A challenge which I faced in this patient was she was having a lot of watering and she appeared quite fatigued. So this was the last station of the day, and it was obvious that she had already been examined multiple times previously. So naturally, she was quite exhausted. So I had to pause my findings, pause my examination, and I asked her to wipe her eyes and be comfortable before I proceeded. He, the examiner then finally asked me, "So, doctor, what will be your differential? What are your findings here?" I mentioned my finding, and he said, "Okay, what are you thinking about?" I wasn't sure about what my diagnosis would be for this eye because I couldn't see well, but I decided to trust my luck and went with the most common scenario which I could think of, which was proliferative diabetic retinopathy. He asked me if I had seen the macula. I replied in the negative because I honestly couldn't make out anything. He showed me the OCT. The OCT had chronic macular edema and asked me, what will you do for her? I answered with the standard strict glycemic control, and then I moved on to anti-VEGF because I was obviously thinking only about the macular edema. The examiner stopped me and said, Doctor, really, will that be your first option? So that was my clue that I was missing the bigger picture. She had fractional bands, so obviously we could not go for anti-VEGF first. I corrected myself and I mentioned PRP. So he seemed satisfied with that. And I did mention that she will require adjunctive anti-VEGF. The bell had rung by then, and he had started grading me. He seemed satisfied overall. So this was the conclusion of my exam. The key lessons which I learned from my entire experience and which I would like to share with you are: one, do not panic. This is only an exam, it is not the end of your life. In spite of the fact that you may have invested a lot of time and energy in this, things may or may not work out in your favor. Either way, you have to give your best performance and always keep the bigger picture in mind. Second, keep things simple. The examiners are not interested in the depth and breadth of your knowledge. They are not bothered about it. They want to know if you are a safe doctor and if you can be trusted not to mess up the patient's eye. So keep your answers very simple and always, always, always answer in a way which puts the patient's life first, then the eye, and then finally the patient's cosmesis and other demand. So your answer should always be in that order. Maintain a calm demeanor in spite of the fact that you may have setbacks during the exam. Don't show that you are panicking. Your exam is ultimately a test of how well you handle stress. So they are also monitoring the way you react to these situations. Drink lots of water. I did notice that I was getting quite dehydrated. So please drink a lot of water. It is very important to stay hydrated during the exam. Stay away from unnecessary discussions and avoid negativity. Avoid people who are discussing about how a previous candidate failed the exam because of some mistake he did, or how the pass percentage is poor and so on. Take a walk outside the waiting room if necessary. I was fortunate to pass this exam on my first attempt. It is in obviously hard work plays a huge role, but in the end, luck is also a factor. Dr. Muthusamy and the Muthusamy Virtual University Postgraduate Ophthalmology Group were a major influence on me. I would recommend all of you to join the group. It is definitely a game changer. I learned a lot from my teachers and colleagues there. My ultimate goal in giving this exam was to improve my comprehensive ophthalmology skill. And in that goal, I have been successful. Moreover, I have made new friends and engaged in meaningful academic discussions and cleared up a lot of my concepts. Dr. Muthusamy very famously told me once that the harder I work, the luckier I get. This is a trademark saying of his. And honestly, I have imbibed this, and I think this exam has proven why he keeps telling me that. The harder you work, indeed, the luckier you do get. And finally, please do not hesitate to email me for any queries. These are my contact details. And this is where I work. This is Chirag Eye Care, my clinic in Prayagraj, Uttar Pradesh, India. If you have any doubts, you are always free to come to contact me, and I will be more than glad to help. I hope that this video has been helpful to you. Thank you.